All right. Hi, everyone. Thanks for joining us. My name is Jeff Ladolter, and I am the Program Manager for the Tribal Opioid Response Technical Assistance Grant through the National American Indian and Alaska Native Addiction Technology Transfer Center, or the ATTC. I'll be your point of contact for TA questions, and my email is on the screen under Contact and Support. Our center is a NADAC certified educational provider, and we'd be happy to provide you with CEUs for a $15 fee. The CEU request form is available for download in the Files pod in the webinar screen, and I will also be sending this form in a follow-up email to all who attended. Immediately following today's webinar, you will be redirected to our GPRA evaluation. SAMHSA asks us to evaluate our events in order to provide improved performance assessment and accountability, and this survey asks about your satisfaction with the event, and it will take less than 5 minutes to complete. We all thank you in advance for helping us to improve our programs, and filling out this form would really mean a lot to us. Participants will be muted for the duration of the webinar, but you can use the chat pod to share your questions and comments, and we will address these questions at appropriate points during the presentation. I'm very happy today to have Pamela Baston and Kathy Myers as today's speakers, and I will let them introduce themselves.
Great, thank you, Jeff. So, hi everybody. My name is Pam Baston. You might have crossed my path at some point in MeU when we did the training on the strategic planning. I have been in the substance abuse prevention and treatment field for 39 years, working at both community levels and state levels, and then in the last 20 years working across the entire country and also with multiple tribes. My co-trainer today is somebody who I think very highly of, and her name is Dr. Kathy Myers, and I will have her introduce herself as well. Kathy? And we have to unmute Kathy. So while the unmuting process is happening, what we can do is skip forward, and when Kathy gets to her section of the presentation, we'll have her introduce herself then. And so maybe Jeff, you and Kate can work on that little technology hiccup. Just so you know, we did do a practice run and everything went great during practice. So anyway, what we're going to be covering today is opioid use prevention with a specific emphasis on preventing the non-medical use of prescription drugs. This particular topic is informed by a number of resource documents, one being the National Tribal Behavioral Health Agenda. Hopefully most of you have seen that document. It's fabulous and gives lots of great background information and has very carefully crafted goals and objectives that address a myriad of issues that are important to this behavioral health work that we all do. The one major objective that this training will address is raising the awareness and also bringing prescription drug misuse and abuse prevention activities and education to schools, communities, parents, prescribers, healthcare professionals, and other patients. So it's a very broad approach. There are also 4 other documents, and we show these little thumbnails so that you'll know what it looks like if you run across them. And this one little at the bottom center of the slide is a link that will take you to a page that has all 4 of the next documents on it, so you don't have to go to each one individually. But these are very helpful resources on this topic from the Substance Abuse and Mental Health Services Administration, SAMHSA, and they each have a little different focus area. So the one on the left you'll see are data resources. You know, how do you go about collecting data around this issue and what do you do with that data when you collect it? The next one is understanding who is at risk. You know, you might know you have a problem with opioids in your tribal community, but just knowing that doesn't necessarily tell you, well, who exactly is contributing to those challenges in your community? You know, is it youth? Is it adults? Or is it women, pregnant women? Is it everybody? You know, is it older people who accidentally are having trouble misusing their prescriptions and such? And so these particular documents will give you the background information you need to know how to go about drilling down. Then these last two, overview of factors and strategies, and that last one is programs and strategies. And these last two are the ones from which the majority of the content from this particular training is coming from. Also want to remind folks, I'm sure you have been here 1,000 times, but the Indian Health Service has a fabulous pain and opioid use disorder website, and my favorite part here is the medication-assisted recovery. If you look to the left, there's, you would click on that, and there's just a treasure trove of information to help you in the work that you're doing with the Tribal Opioid Response Grant. So the non-medical use of prescription drugs, NMUPD, boy, that rolls right off your tongue there. It has become an increasing public health concern with abuse rates that have been rising rapidly since the late 1990s. And some folks may not know this sort of difficult history that got us to this point that we are today. That is that the U.S. Food and Drug Administration, the FDA, approved OxyContin, an opioid pain-relieving medication, and other opioid pain meds back in the mid-90s, and these were originally developed, these pain medications, for short-term pain only. However, the doctors, physicians quickly started prescribing these effective new pills for long-term chronic pain management, which they were never intended for that purpose. And when patients began to build up a tolerance, and so you might remember that tolerance is where you have to take more and more of the same substance to get that original level of intoxication or that original feeling you were going for. And so what happens with these pain meds is the patients begin developing tolerance. So every 4 to 8 weeks, the level they were taking no longer is effective, and they have to up the amount more and get, higher doses and so forth. And because the pills stopped working. And so these doctors and pain experts would, or the pain experts and the drug company representatives kept telling the doctors, well, just give them more pain relievers, give them higher doses. These are harmless. These are not going to be a problem. They assured the doctors that these pills were safe and non-addictive, and they were wrong. And those decisions that were made back then are sadly responsible for a large part, not all, but a large part of the opioid epidemic that we have now. And you're probably aware there's a lot of lawsuits that are in place now trying to hold folks accountable for this. And so, many individuals that are in your tribal communities or that you come across in your work may very well have started out doing nothing more than taking their prescription that their own medical prescribers had told them to take. If they had a car accident or a kid that had a sports injury on the football field or, lifting weights or volleyball, and they went to their doctor and they did everything they were told to do, and lo and behold, they ended up with taking more and more and for longer periods of time, and they're, got into trouble with these legal substances. And then when they were cut off of their prescriptions, they have developed such a dependence that they often will go back out on the street and look for counterfeit medications, or will look for other people to sell them legitimate pain meds, or they even turn to heroin. So these are all sort of historical things that happened over the last few decades that led us to where we are today. By the way, all of these things that we're talking about today, the references for them, if you want to learn more about them, are at the end of the presentation, so you can learn more as you have interest. So other factors led to the opioid crisis that are facing us today. One is that, we used to have what we call 4 vital signs when you would be in the care of, let's say, a physician or in the hospital for some reason. The doctors would be concerned about the vital signs like your blood pressure, like your some respiratory issues, your pulse, your temperature, respiration rate. And what happened is they began calling pain the fifth vital sign. So they made this so important for doctors to manage. And even if you were in the hospitals were being rated by patient satisfaction. So if the patients became unhappy because they had a lot of pain and they weren't getting enough relief, then the patient satisfaction scores would be bad and the hospitals would lose money. And so they were incentivized to make sure all the patients were happy, all of them were satisfied, and so that fed into managing pain in such a significant way that it, again, has caused some of these problems that we're having. Other contributors to the dilemma that we're in today is inadequate healthcare professional education, so that a lot of the healthcare folks that work in this field don't always understand all the issues that go with opioid use disorder. And also there's a diversion problem, a little less today than in the past. But remember that you've got these pills that are that are manufactured in a facility, and then they go to a like a middleman, so to speak, where those are then that individual or that company then in turn gets them to the pharmacies. And so at each step of the way, until it then eventually gets to the patient, there is a possibility of diversion, where either they have an inventory control problem or somebody fails to report that they're getting suspicious amounts of requests for medication. So there are diversion problems that happen all along the way. The interesting thing is that we, since 1999, there's been a quadrupling of pain medications that are made available to individuals, but yet the pain that we have remains unchanged. So there's no reason to have a quadrupling of these prescriptions for pain meds. So this is just, by way of a background to let you know this is all contributing factors that got us to where we are today with this enormous epidemic that we have. So let's talk for a minute about how Indian country has been affected. And obviously this varies depending on where you are in the country, but during 2013 to 2015, the rate of fatal opioid overdoses was nearly 3 times higher among American Indian and Alaska Natives compared to whites. And if you knew that, now this happens to be, this particular statistic comes from a study that was done by the Northwest Tribal Epidemiology Center, and it was specific to that particular area. So obviously you want to know, well, what's happening in your tribal community? Are the fatal overdoses happening, are they growing? Are they stabilizing? Are they reducing? What contributes to that? Who are the individuals that are being most affected by these overdoses? In this particular study from the Northwest Tribal Epidemiology Center, they found that it was young men, 25 to 54, that were having the, actually a doubling of the odds of dying of an opioid overdose when compared to their similarly aged white peers. So these statistics are just ones that are really more important for you to know what are they where you live and what do you need to be concerned about. So the rates for overdoses specifically linked to heroin were more than 4 times as high. And so, that's something else you want to understand. What is it that you're battling? Are you battling the, rise in prescriptions? Or as we now know that around the country, there's been such an emphasis on not prescribing as freely and as much and for as long of a period of time as we used to, that now there's been, some laws and policies, depending on where you live, that you might see happening where now, doctors that used to prescribe months and months of opioid prescriptions at a time might now be only giving a patient a week's supply and then making them come back in, to verify that they still need it as a way to try to minimize this. And that helps in some ways, but it also then drives some individuals out to the street, because if they're not able to get the medications that they felt that they needed or that they have now become dependent on, they will find those medications in other places. And sometimes that's counterfeit meds that they get off the street. Sometimes they're taking them from other people's medicine cabinets, and sometimes they are turning to heroin, which can prove to be a very similar high, and oftentimes even cheaper and more accessible. And again, this varies tremendously wherever you live. So other populations of concern are pregnant women, and we know that about 60 to 80% of women who are using opioids while pregnant, whether they are using street opioids like heroin or medications they get on the street, or whether they are in a legitimate medication-assisted treatment program, let's say getting methadone or Subutex, they will have, there's about a 60 to 80% chance that regardless of how they're having opioids in their system, that the babies could have neonatal abstinence syndrome, NAS. The good news is that as of at least this point in time, we have some really good ways to address this problem to minimize any discomfort with the infants, and also that we are not aware of any long-term effects that have been documented. There's various theories, but in terms of any concrete research at this point in time, there is none that indicate that there's any long-term problem to the baby. But the issue here is that if this is happening in your community, which we believe is happening everywhere, that you have women who are pregnant who are using opioids, if they are using street opioids, they're on a roller coaster, they're up and down, because you never know what you're getting on the street, what the quality is, the volume, whether it's pure, you know what people tell you it is, but you don't know what it really is. And so mom and baby go on this roller coaster ride depending on how often they get their opioids illicitly, how strong they are, and so forth and so on. But if they are not fearful of acknowledging that they have an opioid use problem, and they are not, and if you do a good job in your community of reducing the stigma, and they feel like they can come in and admit that this is an issue in that they're struggling with, then they are able to get on a medication-assisted treatment that will stabilize them and the baby, and so that they are both very comfortable. If they're able to be upfront about this, the hospital knows, listen, mom may be delivering a baby that has neonatal abstinence syndrome. Again, not every baby has it, but about 60 to 80%, and there's still a lot we don't know about why. Some do and some don't, but we know it's not dose-related. We know that it doesn't make sense to lower your dose of medication-assisted treatment, lower your dose of Subutex, let's say, or lower your dose of methadone, because we know that doesn't have an effect on whether your baby has neonatal abstinence. But if everybody can be above board about this, then we know we can help mom, we can help the baby, we can make sure that the baby isn't taken away by child welfare if they know that mom is not using street opioids, but she's in a legitimate program, getting lots of support and structure and people checking on her and the baby. And so this is why you need to know what's happening in your community with this population and find out what else is happening. And I'll show you a slide that will explain this in a little more detail. But basically, in this other study that was done on pregnancy and neonatal abstinence, it found disproportionate rates of maternal opioid use and NAS among American Indian and Alaska Native populations, as well as any woman who was on Medicaid, and sometimes those are overlapping populations, when compared to white and privately insured groups. And women who were between 20 and 29 years of age had the highest rates of opioid use. So, data tells you something happens or doesn't, or it's not happening, but it doesn't tell you why. Why is this happening with a particular population? And so that's one of the things that we want to make sure happens here, is that we start to drill down and say, well, why is this happening? This is a very dramatic slide here, and this was a study done in Minnesota. This is not a national data set here. This is from Minnesota, but you can see this dramatic 8.7 times increase, or American Indian women were 8.7 times more likely to be diagnosed with maternal opioid dependency during pregnancy. And one of the questions, so that's basically 1 in 10 pregnancies have this diagnosis among American Indian women. So one of the questions you might have here is, why is this happening? So we know when we look at the next slide, we get a hint about why that might be happening, and that is that the moms are less likely to have come in for prenatal care. So one of the indications that some hospitals will use to determine if they're going to test a mom or baby is if mom has avoided prenatal care. Then they assume, well, geez, if she's avoiding prenatal care, she's trying not to, have her drug use detected, or she's hiding from something, and so they're more likely to test her. So, and there could also be racial profiling. We've known that to happen. So basically, the point here is that we do know that there are a number of studies that do show a disproportionate rate of opioid use during pregnancy and also associated neonatal abstinence syndrome among American Indian and Alaska Native women. We don't always know why that is, but this is an opportunity with you having the various tribal opioid response grants. And I realize some of the funding is not significant enough to allow you to necessarily drill down as far as you want to go, but it at least alerts you that if you're not already aware of this, to see, what contribution you can make or who you can work with. Maybe there's other resources that can be leveraged to get a better understanding of what's happening with the various populations that are contributing to the opioid problem in your tribal community. So here's another study from this one involving youth. And this was where they did a study of American Indian students compared to students in the broader United States, and they then compared them to see what was happening around all drugs and alcohol. I just plucked out heroin and the narcotics other than heroin, which would be, pain medications and those kinds of things, and just to see how does this compare. And so again, less important what this particular study says. I'm just using this more as a way to demonstrate a couple of things here. One is that you can see the first chart on the top is lifetime prevalence. That just means, at any point, if somebody ever used a substance, it would fall under lifetime, whereas the little chart below is past 30-day prevalence, and that's what we call a proxy measure for regular use. So the top chart would be somebody who might have used something even just once, and the bottom chart would be really those folks, those kids in this instance who, students who were using more regularly. And so what you can see here is that not only was there a higher use rate among American Indian students, at least as reported in this particular survey, but what is more important possibly is, look at, for example, if you look at the very first line and you see, and let's just look now at the American Indian data. So in the 8th grade, you've got 2.8% of the students admitted, these are self-report, admitted to heroin use in the 8th grade. Then it went down just a little, not significantly, in the 10th grade, and then it goes back up in the 12th grade. And you can look the same way for narcotics other than heroin, and you'll see this is a significant concern that 3% of 8th graders admitted to using narcotics other than heroin. But look what happens between 8th and 10th grade. There's a tripling of use, just about, not quite. But, oh, hey, Kathy.
Did you hear me?
So, yes, we can hear you. Go ahead. Kathy, are you weighing in on this slide, or you're just letting us know that your your microphone has been resolved.
Sorry about that, Pam. Just trying to get Kathy into the room here.
Thank you. So if you were, trying to provide prevention of opioid use in your community among youth, and you saw that using your data, you don't have to use this particular data set, that, what the heck is happening between 8th grade and 10th grade to have such a spike in youth? There's a lot of background noise there. So what that would just point out to you, hey, here's an opportunity that we need to learn more about and find out why is there this big increase. And then, so you might do focus groups, you might meet with some of your tribal leaders, your tribal elders, you might meet with some parents in your tribal community and the kids themselves and do focus groups or key informant interviews and try to find out what the heck is going on here, and then maybe, learn more about what your strategies might be. And then it continues to go up, you can see, in the 12th grade, but that almost tripling between the 8th and the 10th grade is certainly something that jumps out quite considerably. And so I don't want to dwell on this particular slide. These are just, brief examples of showing you the importance of using data to figure out what is going on in your community and how to decide where to intervene. So while there's much higher rates of opioids other than illicit drugs, alcohol, and cigarette use existing among American Indian and Alaska Native youth, at least according to these surveys that we have reviewed and others that are out there, the study reinforces the need for early prevention efforts for all youth, not just the youth that might be using and showing up in these surveys, but all youth could benefit from our prevention efforts, and that it's important to use culturally sensitive intervention materials and strategies that take advantage of the inherent strengths and traditions of Native American people. So non-medical use of prescription drugs, we look at, when we want to prevent and reduce this issue, it's a big challenge for us, and it's because it's different. It's very different from the other prevention efforts that we have implemented in the past with other substances. And that's because there's a lot we don't know, about opioid use, and particularly around prescription use. And where we know a lot more, let's say, about alcohol or about tobacco and other substances, we still are learning a lot, especially about the factors, the risk and protective factors that contribute to such use. And then also, this non-medical use of prescription drugs also means that we have to work with different intermediaries, different partners. So we might now be working more with medical community, with first responders, with groups that weren't necessarily at our table before, with maternal health care, with neonatal abstinence nurses that work in that area. And just as a quick aside, I do a lot of training nationally on this subject, and I was in Florida meeting with a group of behavioral health providers, and some of them were literally in tears talking about how when they would take their mothers who were on medication-assisted treatment in a residential program over to the hospital every day to see their babies who were born, and they were, trying to breastfeed the babies and nurse the babies, even though that's the absolute best thing you can do for those babies, unless you have HIV or, and you can even do it if you have hepatitis C, as long as you don't have, cracks in your nipples or other dangerous ways that you could have blood transfer. These nurses were pouring out the breast milk, were showing all kinds of stigma to these moms who were trying so hard to, and they would say, we're trying to be good moms and do it the right way this time. Maybe we've lost other kids to the child welfare system, or we didn't do right by them, but we have this new beginning. We're in treatment. We're doing well. We want to do a great job. And then to face all the stigma with these nurses who either didn't have the education to know that, not only do you want them to breastfeed if they're willing, is that it helps strengthen that bond between the mom and the baby, and it also helps reduce the neonatal abstinence syndrome symptoms for the baby if the baby has that. So by what those nurses did, they literally caused harm to the mother and harm to the baby, And whether they intended to or not, we'll never know. We don't know who they were. But it does open up the need for us to do a better job educating. We can't assume just because they're medical professionals they know everything. And especially when it's around stigma, there's just a lot of work we all collectively can do in that space to make it better for these moms. But there's other reasons why we need to do education, and we'll talk about those later. So these are different people that we may not have worked with, and it may be intimidating to deal with medical professionals, especially if we're lay people or people in recovery that may not have a big education behind us, and now, we have to deal with people that we might think would look down on us or not value what we have to add to the field. And so these are challenges that we have to face with opioid use that we didn't have with these other drugs. Also, the other little tricky thing is that the reality is that prescription drugs, when taken as prescribed and when dosed appropriately, have important health benefits. So, it's hard to work, when you're dealing with cocaine, for example, or heroin, obviously there's no medical value of those. But when you're trying to combat a substance that may be taken in a way that has actual health benefits, it gets a little tricky. So who is at risk? This is a multi-level framework that shows, for us to do the most comprehensive job in opioid prevention, what we need to do is to recognize that starting in the center of the circle, the individual, it's important to focus on individuals. They have biogenetic predispositions and certain characteristics of their family that they were born into, and the genes that they have, and their individual opinions and their viewpoints and their beliefs. They also, we also have to look more broadly at the relationship, because they're not living in a vacuum. They're living with being influenced by family members, by peers, and so we have to work with the other relationships that they have. And work with the people that impact those relationships, including teachers and parents. And then they live within a tribal community or within a community that includes people that can influence their behaviors in good and bad ways. And then also in the broader society. And in that broader society, the importance of recognizing culture and historical trauma. All of these variables and everything listed here and more all influence whether somebody is at high or low risk of developing an opioid use disorder, and also are important to include in the efforts that we develop to address this epidemic. So we're going to take a minute and look at opioid prevention because the work that we do can occur at 3 basic levels. You might decide you're going to do it universally, meaning everybody. You're going to implement a program or a strategy or a policy or something that will affect everyone in your tribal community, no matter their age or, regardless of what risk they have or protective factors they have, if you want to hit everybody. So an example might be serving everybody, K through 12 in school, or a campaign that is on the radio or television or social media that is designed to reach everyone in large numbers. And often you don't even know how many people you're reaching because of the way it's delivered. But if you decided you were going to do selective prevention, that's where you determine that you're going to focus on people where there is already some risk that you know about. So one example might be you might decide to do something with every child that is living in a home where a parent has an opioid use disorder. That might be a selected population. They're already at risk because their parent has an opioid use disorder. Or maybe you decide to work with children of parents who have overdosed, whether, if they've lived, for example, whether they've lived or not, whether it was a fatal overdose or not, maybe you're going to work with those children. So if you work with, when you work with groups of children, or you work with ones who, because of the group they belong to, that being a child of an opioid user or a child of an opioid user who had an overdose, that's selective. When you get down to identifying individuals, if you say, I'm going to work with Ren Daw, because she has shown up at school with some behaviors that we believe indicate she might have an opioid use. She might be dabbling in opioids. Maybe not to the point of needing treatment, but you see some behaviors that say she is at tremendous risk. We're going to focus on REN, or, you know, a group of, you know, maybe you identify multiple individuals. So again, universals, everybody. Selective is groups of people who, by the nature of that group they belong to, that being a child of a opioid user or overdose victim, might need extra help, or indicated would be when they are an individual who has raised your concern for some reason. So this particular thumbnail that you see on the right of this little manual, the majority of the slides that we cover from here on come from that particular one. I told you there were 4. This one's called Programs and Strategies. And you might remember that when you wrote the application for your Tribal Opioid Response Initiative, that one of the requirements was that you implement evidence-based prevention. And so part of why we're doing this webinar and why we use this particular SAMHSA set of guidance documents as well as a few others is because this particular one and the slides that follow were programs and strategies that were specifically selected because they were from studies that were done between 2005 and 2015, and that they were based on actual quantitative data, real data that was gathered, not necessarily just anecdotal reports that you heard somebody said this might work, that there was actual documented evidence. Also that it was published in a peer-reviewed journal, and so by that we mean, you know, where there was some level of, it was closely examined by a panel of experts, the research, to make sure that it met a certain level of rigor or that it is otherwise believable. And that also to be in this particular manual that you're looking at there on the right, it would have had to have been an evaluated prevention program implemented in the United States, and it had to address non-medical use of prescription drugs. And then the last thing is it had to demonstrate statistically significant positive effects. Now, granted, the type of rigor of the study in which it demonstrated effects varied considerably, but we are working with what we have here. So we're going to walk you through, I'm going to walk you through one now on education, and then Kathy's going to come in and do a couple, and then I'll follow up at the end. And so what we'll walk you through is different types of strategies and programs on the non-medical use that might be of interest to you, and you might already be implementing some of these. So what do we consider to be education? SAMHSA considers education to be implemented to increase awareness of prescription drug misuse dangers for the public and healthcare providers. And so what's interesting about that is, you know, we usually just do our educational programs to schools, to students, to parents, you know, to teachers. And so when you deal with non-medical use of prescription drugs and even other opioids like heroin, we suddenly now kind of get more into the healthcare arena because we know that that's a critical partner for us, and also they may end up there with medical problems, you know, overdose being one. But so it also, education provides opportunities to teach individuals how to properly dispense, store, and dispose of the controlled substances. So any program that kind of fits those parameters is considered an educational strategy. As most misuse opioids come from social sources, so if you're not aware, the majority of the opioids that are especially prescription related come from family and friends, free. They don't come from doctors. So when they come from someone else's medicine cabinet, or somebody gives it to their friend, or they're taken out of their medicine cabinet without their knowledge. So we really have to focus. One of the educational strategies that's important is to make sure that individuals who have prescriptions understand how important it is to keep them under lock and key, to not share them with others, and to keep them safe. 2 other quick points I think I might have mentioned in a past webinar. Even realtors who have open houses are now discovering that the people that own the house that might leave while their house is being shown as, to people that are interested in buying it will come home and find their medicine cabinets cleaned out. So that's an issue. And we also want to, just as an aside, when we know that our pregnant moms are coming home from the hospital, and if we know that they are on medication-assisted treatment, we want to make sure that when we have visitors to the house that are all excited about coming to see the baby, that we remind mom, keep your medications out. Don't have it sit right next to your bed, or don't leave it in the bathroom on the counter, because even well-meaning people, if tempted too much, could those medications could end up in the wrong hands. So the ability to educate them about how to reduce access, unintentional access, is critical. Also, there's a program I'll show you in a minute in Alaska, very successful, where parents were taught the dangers of prescription drug misuse, and in Alaska they used these interactive family night sessions where they had, I think it was 2 or 3 different family sessions. They usually had the kids leave the room and the parents were there alone, and they would then talk to them. I think they might have brought the kids back in later, but they talked to the parents about how to restrict access to prescriptions that might be in their household, and also other household dangers like remember we used to have a big problem, and maybe still do, with inhalants and aerosols, and I know some of that's come down, but other household dangers that kids can use to get high. And so this program also cultivated a greater parental disapproval towards prescription drug misuse, and that's an important protective factor for youth. So that this is what you're going to see, several of these charts like this, both on my time and when Kathy presents, and we're not going to cover every line in here. The intent in putting them in the webinar is just to give you an idea of what kind of helpful information you can access through these documents. And hopefully, Jeff, maybe we can put these up on the TOR website too to make it easier for folks to find these. But anyway, you can go through the back of some of these manuals, and you'll see, and you can read a description of the program and who would it serve and what settings. This was in rural frontier Alaska communities. What were the risk and protective factors that the program focuses on? In this case, it was ease of access to harmful legal products, including prescription drugs, and also strengthening the protective factor of parental awareness. By the way, if you want to learn more about risk and protective factors specific to opioid misuse, again, one of those 4 documents that we put at the front, and we'll show you again, we'll give you that information. And so you can then, learn more about this. You can see what the outcomes were, and also, which in this case where parents were more likely to restrict access to their prescription drugs, and also there was a decrease in the availability of prescription drugs, which is also a good thing, for reducing future use. Here is the link that would take you to learn more about this particular program. Here's a quick one done in Utah, which focused on using a lot of social media. It was a big media campaign, multimedia campaign in Utah that talked about not sharing prescription drugs, and and if you go to this next slide, you can read more about it. Again, seeing who it was for. This might even be another program in Utah. They had several. Where the settings were the media outlets and channels, and what the risk and protective. In this case, their risk and protective factors were a lack of knowledge about the risk of prescription opioid use and misuse, ease of access, and the prescriber's inability to identify other risk factors in patients. So they did a multi-pronged strategy of educating different groups. And again, you can learn more. Again, we don't have time to go into all these outcomes, and some of these may not be of interest to everyone, but just know that this is the rich kind of information that you can get from this SAMHSA document, and look for to see how you always want to target risk and protective factors. So you want to find programs and strategies that kind of align with the risk and protection factors that are in your tribal community. So also other educational strategies, they aim to reduce access to and availability of prescription drugs for those who are likely to misuse them. It can target drug prescribers, so what we call prescriber education. Evidence suggests that prescribers that are taught best practices for opioid prescribing and that are provided the information regarding opioid dosing guidelines are more likely to safeguard against potential patient misuse. So this is getting at, there are a number of educational strategies where we have, docs talking to docs, nurses talking to nurses. It's not always up to us to have to do the education. Sometimes it's better. I know when you have situations where you don't have a lot of prescribers willing to prescribe medication-assisted treatment, they're nervous to work with opioid-using populations, even though they already have them in their practices and often don't know it. Sometimes it helps to have a doctor or a nurse who's already doing this work say, let me tell you about my experience and how rewarding it is and what you might need to look out for, and so teaching each other how to do this. So these are some other little things that you can do. These are, there's a lot of different versions of these, but these are pill dispensers called smart pill dispensers. And what they do is they put timers and locks on so that if you're only supposed to take your legitimate pain medication at a certain time each day, it not only helps you as a person that might be taking a legitimate opioid pain medication, it lets you know when it's time to take your next one, but it also restricts access from others in the household that might be trying to slip a few pills out of the bottle. Well, they can't do that now. Now, yeah, they can walk off with the whole thing, or they could crash it, break it, and open it up, but you're obviously going to notice that. But this does help in some ways. Where this helps probably the most is that sometimes we have older patients who are get more forgetful about when they're taking their meds, and they might have somebody in the household, including a nurse that's there, maybe an in-home nurse that's coming to help them that could be taking the pills and convincing the older patient that they've already taken it, that they must have just forgotten that they didn't take it, and so, or forgotten that they took it. So these dispensers do have some utility. They're working on one now. It might already be out where you use your fingerprint. Biotechnology is a really booming area now that you'll see more of. This is fascinating. This is a study that was done where they looked at all of these doctors that were having, I think it was 800 and something doctors that they randomly identified, and found out from those doctors how many people died that you were prescribing opioids to. And it was, I want to say it was 170. So among these 861 doctors, there were 170 patient deaths who were getting prescribed opioids. And what they did is they started having the medical examiner contact the doctors with a standard letter, dear doctor, please be advised that your patient, and then they would say the patient's name, was just found overdosed on opioids, and they were your patient. And so apparently by something as simple as alerting in a letter, this doesn't cost very much money, alerting them to the people that died on their watch, so to speak, they brought down by 9.7% the number of the amount of opioids that were being prescribed, especially high-dose opioids, when compared to a control group. So these are, again, you can find out more information by the citations at the end, but this is just to let you know, just to give you kind of a smattering of the different kinds of opportunities that might be out there for you that you might consider, and some of you might already be doing. Also, carefully crafted educational strategies are vital to community prioritization. Sometimes you just have to prioritize. What are you going to do? There's so many different problems and so many different populations experiencing these problems, and there's so many different ways you can go about it, but you have to be very strategic about how you decide to kind of zoom in and on whom and with what program or strategy. So you really have to have a good understanding of the problem, and a lot of this will come from your own knowledge of your own tribal community and working with your elders and your leaders and the populations themselves that have struggled with these problems to better understand them. Now, just handing out pamphlets alone, disseminating information alone, does not generally change anyone's behavior, but it's not a bad strategy in that it does help change perceptions of harm and future intentions to use. It's just that if you're going to be doing information dissemination, just know that that's only part of the job, that you want to make sure you connect that educational information dissemination effort to something, to the next level, of programming, of social media, of meeting with parents, of programs in schools. You just want to have this multifaceted approach. And that's basically what we call a comprehensive approach, is combining strategies that target multiple risk and protective factors. And those are the ones that show real promise in reducing non-medical use of prescription drugs. And that address, remember that big circle I showed you called the socio-ecological model, or socio-ecological levels, where you're looking at the individual, their relationships with others, their community, the society, and your, and culture. So to select relevant strategies, you have to look at, what do you see, what data is out there, review the literature that's out there, look at what tools are available. You're hopefully working in a group with lots of different folks and getting their input, and then deciding at best what risk and protective factors are driving the problem. And the last example I'll use here is, if we were to simply tell you, wow, you're in your tribe, the data says that, say that you have 20% of your tribal members are using opioids of some kind. If you just had a statistic and that was all you had, what would you do? It gives you no guidance. Just knowing the prevalence of something doesn't give you any indication of, well, who are the subpopulations or the groups that are contributing to that statistic of 20% or whatever it happens to be. And so once you start finding out who those are they pregnant women? Are they children? Are they older patients, that are on prescriptions? What is it? Then the next thing you do is you have to figure out, well, what are the risk and protective factors that are contributing to that, so that's how you actually determine what program or what strategy to pick. So I know we're covering a lot in a short time, but again, encourage you to review the documents, the 4 SAMHSA documents that we provided at the beginning, and to also the tribal agenda provides a great resource. Oh, I did want to go back and say this one important thing from the tribal agenda. There's the action, looks like 2B number 5, and it says involve American Indian Alaska Native youth in the identification and planning of strategies for the prevention of youth violence, substance abuse, and suicide. So the National Tribal Behavioral Health Agenda was recognizing how important it is to involve youth. I would say, and there might be other action steps that say this in the tribal agenda, but I would say involve all populations. If you're going to work with pregnant women, involve those women, having them help inform how you go about the work that you do in prevention, and how to design and deliver and disseminate your prevention strategies and programs. So at this point, I'm going to kick it off to Kathy. And Kathy, if you could introduce yourself, since you didn't have a working mic at the top of the webinar. Kathy? Jeff, can you hear me?
Yes, I can hear you just fine. We may not get Kathy out.
Okay. All right. So what I will do is I'll start going through this, and she can happily interrupt me at any time.
Can you hear me now?
Yeah,
Pam?
I think I heard her. Yes,
Pam?
yay, Kathy, yay.
Okay.
Yes.
Yeah. So, yeah, I apologize, everyone. I am not very savvy, I think, with computers. So I've been really struggling here a little bit today. But anyway, I'm Kathy Myers, and I'll talk with you a little bit about how different communities are tracking and monitoring the opioid epidemic in general, and then different prescription medications in particular. I'm co-leading the national evaluation of the STR dollars, with many of you may be aware of, the state targeted response to the opioid epidemic dollars. and we're getting a lot of important information about what's going on around the country. So one of the key pieces of tracking and monitoring that states and territories are doing is trying to identify a couple of different things. One is, who are the drug seekers and how can we get them into treatment? So are they doctor shopping? They're going to a variety of different, whether it's emergency rooms, federally qualified health centers, private practitioners, to get multiple opioid prescriptions. And in an attempt to reduce access and availability, and then to try to get individuals into treatment. Doctor shoppers is really a term that was designed or came up many years ago, and it's really held on, and it's really for those individuals who seek out prescriptions from multiple individuals. And then it also looks at trying to identify prescribers who are overprescribing. So at the individual level, we're trying to identify patients who are looking for multiple prescriptions. At the prescriber level, we're looking at prescribers who may be prescribing too much, too often, and to too many different people. The thinking being that if you can identify people who are doctor shopping, you could potentially reduce either the long-term addictive potential by curbing it or getting individuals into treatment. From the prescriber part, what you want to do is identify prescribers that are knowingly overprescribing for financial reasons, as well as those who may be overprescribing because they're not aware of guidelines. And Pam talked with you about the different types of training programs that are available for prescribers. One of the ways that we do this is through prescription drug monitoring programs. Some of you may have heard of these. Maybe some of you are using either your own that you've designed or you're using your local state or communities. And one of the things I want to say throughout this is what we're going to tell you about in terms of tracking and monitoring is really to give you an idea of what some of the tools might be, and then you determining whether or not you can adopt them or adapt them to better meet the needs of your particular communities or the culture of your communities. And then importantly, if you have adapted them or you are using certain things successfully, whether you can get involved in speaking to other communities about how that's happened. And one of the things that has come up with some of the state directors has been that professional to professional trainings, including tribal community members, talking to tribal community members, has been very helpful in combating the epidemic in certain communities. So I just want to put that out there. So prescription drug monitoring programs are basically databases where you are required to enter and track prescriptions of not only opioids but other controlled substances. So think about when methamphetamine first came online, the ability to get cold medicine with certain ingredients was drastically curtailed, and now you have to give your license, you have to sign different things away. So it's very similar to that, but now it's with opioids. So it allows prescribers as well as law enforcement to track this. But the devil's in the details. And so one of the things that has not been really addressed well is that, yes, these databases exist in all but one state and territory in the country. There are legal requirements or legislative requirements in certain states and territories that require prescribers to enter the data into the database. But on the flip side, there is nothing that teaches prescribers on how to use the data or what to do should they find a patient who's looking for substances. And so I think the next step in this is really working with prescribers to understand how to deal with someone that they have seen just comes up in a database. And some of the doctors that we've talked to over the course of the last 2 years have said that they don't want to look in the database because they don't know what to do with those patients. They don't know how to diagnose an opioid use disorder. They don't know where to send someone with an opioid use disorder. They don't know what the options are for treatment for an opioid use disorder. So that is a key piece that needs to begin to follow the PDMPs. The other is that there is not state-to-state sharing of data. So if you live where I live on a border area of Pennsylvania. I could go to Delaware, New Jersey, Maryland, and in PA, all within a 45-minute to an hour drive of where I live. So I could easily then get multiple prescriptions from different doctors in different states that would not be able to be tracked. So it's a step in the right direction, but there's still a lot that needs to happen in order to get patients who are identified as frequent, many times we call them frequent flyers. They fly in, get their prescriptions, fly out, and then fly to another individual, to identify them and get them the treatment and the care that they need. And then there's the legal piece. In terms of law enforcement agencies monitoring, there are a number of prescribing regulations now that restrict dosage, duration, number of prescriptions. And so will those databases be monitored to see who is overprescribing? And it may be that's the only prescriptions that a certain physician would prescribe. And then we know that that's quote unquote a pill mill. And a pill mill is basically someone who is indiscriminately and even purposely dispensing controlled drugs basically for profit. And actually here where I live, last month there were 3 pill mills that were shut down within one county. I'm not sure how they got the data, but there were 3 physicians who were actively providing many prescriptions for opioids, and they got turned back. But the other big piece is not all physicians are aware of the danger of opioids. I think, we read in the news a lot that pharmaceutical companies have done a really good job at marketing opioids for pain relief without discussing all the risks associated with long-term use of opioid prescription medications. And so if we can identify physicians or other healthcare practitioners who are prescribing medications and not really doing it in a way that is appropriate, can we bring them into some of the trainings that exist around the country? And there's a fair amount of trainings on opioid prescribing guidelines to help those physicians do a better job at determining whether someone should be placed on opioids at all, and then if they should, what the recommended dosage and duration would be. So again, as Pam had said, in the different resources that will be made available to you, the prescription drug monitoring program is trying to reduce access to prescription drugs, increase physician knowledge. But again, we've got a lot that we need to do. Once you know that someone is using, what do you do with that patient after? And this is where really I think that peers can come in, and I think in the case of tribal communities, whether it's elders, leaders, people that are respected within the tribal community, to interface with some of the physicians so that, one, physicians can be aware of what some of the cultural and spiritual issues are so that they are not inappropriately saying things that may not ring true, and they can kind of wrap their arms around the individual to get them back to tribal members who can assist them on their journey. One of the unintended consequences, not surprisingly, of cutting down on opioid prescribing is individuals will turn to heroin. And as you know, heroin, and Pam has mentioned this, is frequently laced with other things, with fentanyl increasing on the rise. And so an increase in overdose fatalities is not unheard of. So one of the things, if you're monitoring data, you've got to be aware of all of the different impacts that can lead to either increases or decreases in overdose fatalities. So if you're thinking, I'm doing everything right, we're monitoring prescriptions, we've cut down on prescriptions, have you had these individuals who have been doctor shoppers, have you had them go underground and they're now engaged in the drug subculture within different communities where they're going to be much harder to reach? So if we can get individuals engaged in treatment before they get to street heroin, that would certainly be, it would be more advantageous. In addition to proper storage that Pam had mentioned, there are also medication disposal campaigns. And what they talk a lot about within the medication disposal campaigns is they have drug take-back programs. So many times there will be like the first Saturday of every month, bring your unused medications, drop them off. Or in some states, they have take-back lock boxes where you can drop them off at any time so you don't have to plan. The thinking is that if you get rid of medication, they're less likely to be diverted, less likely to have young children get into them, less likely to have people, what you share them or have people take them. But similar to the drug buyback programs, which were fairly common probably about 10 years ago, where states, and Philadelphia was one city actually that did this, is they would have certain days that you would pay to have guns get off the street in the hope of reducing homicides. The drug take-back programs have not, it doesn't appear that they've moved the needle at all in terms of reducing overdose deaths or reducing diversion. And one of the reasons that people are thinking is only about 10% of the drugs that are quote unquote confiscated in a take-back day are opioid prescriptions. So they're old antibiotics, they're old flu medications, but they don't tend to be opioids. But importantly, what the medication disposal, the take-back program days, the take-back lock boxes, it really enhances the knowledge that this is something to pay attention to. And so people are anecdotally reporting that communities are becoming more aware of the dangers of opioid prescriptions and other prescriptions, and are more ready to talk about the possibilities of doing something at the community level or getting more information about what the signs and symptoms of drug and alcohol use might be so that they can help interfere. And as you can see in here, there's been a number of studies done to discuss what in fact these have been, what they've done. And again, I think they get a lot of drugs off the street, but it doesn't appear that they get as much of opioids off of the street. But it is raising awareness, which is also important. And then the last set will be harm reduction. And I think in many ways harm reduction has gotten a bad rap, is that people think harm reduction is synonymous with it's okay to use drugs. And that is not the way in which harm reduction works. Harm reduction is basically, my definition, is saying that if, as we work to reduce access to illegal substances or access to legal substances to be used illegally, as we work to engage communities in prevention, as we work to get people into treatment and recovery, we also need to reduce the harms that are associated with people who are using. So how do we reduce death, disability, or other negative consequences? And one of the key ways that we're doing it, and when I say we, I mean the country, and many of you are, I'm sure, aware of these processes, is through overdose education and naloxone distribution programs. So naloxone is an overdose antidote. Many of us know it by Narcan, and it's basically a medication that when administered during an overdose, you can reverse that overdose and prevent that fatality. There's a lot of stigma in some communities against using naloxone. Some communities feel that if you use if you use it, you're saying that it's okay to use. But other communities are saying we can't save lives or we can't reduce opiate overdose deaths if we don't keep people alive. So know that there are some proponents who are not advocates of this, but we're seeing that as people become more aware of where it fits along the continuum of intervention, communities are becoming much more open to engaging with these medications to keep people alive. And there's three different route of administrations, if you will. There's nasal sprays, auto-injectors, and then injections. A lot depends on naloxone access, and we're going to talk about naloxone access laws in a little bit. Most of the time, community members get nasal sprays. Now, I want to say one of the myths that is being perpetuated is that Narcan and naloxone will not work on opioid overdoses if fentanyl is on board. It's not the case that it won't work with fentanyl is on board. It's that the window for reversing is much smaller when fentanyl is on board. So if you are intervening outside of that window, then the likelihood of reversal has decreased. And the window is much smaller than if it's pure opioids without fentanyl on board. Some of the interesting things that we're seeing around the country is how people are trying to engage patients in treatment after naloxone distribution. So this isn't treatment, this is just to prevent death. Some patients refuse transportation to a hospital, and there's one community that keeps 1 to 2 treatment slots open, whether it's a residential slot or an outpatient slot. They keep a few of those open at all times, and they have a contract with Ubers that if they refuse transportation to an emergency department, an Uber will bring someone from the community to engage with that patient to try to get them to take that next step to go someplace, because as you know, the one overdose, the likelihood of a second overdose is quite high. So while that generally works very well in urban kind of environments, I think, how might that look like in your communities, and who might be able to go out and potentially be on call with first responders to try to bring that patient and bring that individual into some type of an intervention type of a setting. And so you'll see here that they're really being given, there's been widespread distribution, mostly through the opioid STR dollars that have been made available to the states. One of the things that is limited, however, is that there's very little data being collected on where these reversals occur. And I know that obviously first responders, particularly the paramedics and EMTs, have to collect data on that, but it's not really going anywhere. And so there's a lot of discussion on some next steps with naloxone distribution is tracking the reversals for a couple of reasons. For reason number one, to understand what communities may need more than less. So if we're doing equal opportunity and every community is getting the same amount, but the reversals are very different, how do we take the 50 units that we've given to community A, who's only had 2 overdose deaths, take 40 of those 50 and send them over to someone who's had 3 times that amount? But then the other is to really try to figure out how to get peers involved and have peers ready to deploy in communities where the reversals are high. So if we know in community A, there's a lot of reversals, how do we pair community members, whether it be tribal members, peers in recovery, with first responders, or at least have the option to call these individuals so that those connections can be made before the event is over. And then the last is Good Samaritan laws. So, and I'm not sure, I know that some of your communities are may have your own laws, but this really grew out of an intention to do two things: to prevent those who want to intervene from legal repercussions like arrests and prison. So if you are with someone who's overdosed and you called 911 years ago, you would most likely be arrested for possession. And so there was a decreased likelihood that you would make those phone calls. And then for those who may be trying to intervene with naloxone prior to these laws, they face liability if things went wrong. So Good Samaritan laws and naloxone access laws have gone into, have been in place, which basically does two things. It allows individuals who are attempting to intervene, if they are drug users or anyone else, that there will be no legal repercussions for intervention if you are also under the influence. And then it protects first responders from liability should something go wrong. And this has really increased the comfort level of particularly police and firefighters. So when we think of first responders, we think all the time of, or we think a lot of EMTs and paramedics, but police and firefighters also are called into these situations, and it has increased their comfort level in knowing that if they try to help, that they will not be held liable should something not go well. So I think, in sum, there's certainly a lot of good basic ways in which we're beginning to track and monitor this epidemic, to try to reduce access, to try to increase treatment, to try to get people that are most at risk of overdose into treatment programs. But there's a lot of additional work within them that needs to be done. So working with people to know what to do should they see someone who's doctor shopping, work with individuals to get people who have been reversed into a treatment program. So with that, I'll stop and I'll turn that back over to Pam.
Great. Thank you, Kathy. Can everybody hear me okay? So I had to laugh at the Uber suggestion only because I live in a town of 1,600 people, and we don't have Uber, but we do have Super Dave. And Super Dave is an older guy with a car that's probably 1984 Suburban or something, and he goes and picks people up from bars if they've had too much to drink. And that would be somebody in our community that we would try to convince, could you help, maybe help take people that get that overdose and get to the hospital, maybe drive them to a treatment program. I mean, he's used to driving people around who are intoxicated. He might not have a problem, taking that step with opioids. So, I think we all have to get creative, especially those of us that live in rural communities. I also wanted to mention there's still a lot of stigma, even with the first responders. And I mentioned on another webinar that I literally get stopped at our local restaurant when I go to eat by first responders who, they know what I do for a living, and they'll come up to me and ask me, how many times do I have to reverse the same dude from overdosing, and I remind him every time. And they get so upset thinking, like we're enabling them. And so I always have to use the example, if your son were, as many teenagers and teenage boys in particular are wont to do, speeding down the highway in their car, their race car, and they end up getting in a wreck, and you go and the tow truck comes and gets them out, takes them to the hospital, and then that happens again a month later, you don't say, well, I'm sorry, I'm just going to let you die here on the side of the road because we know you're just going to go out and do it again. You did it before. We don't have that stigma for anything other than opioids and other drugs. And so it's really grossly unfair for that to be placed upon these individuals. And we just want to keep them alive. We know it takes about 9 to 11 treatment episodes in many cases to get into stable recovery. So we know that's the case. I also want to mention, and I have to brag a little bit on the Sisseton Wahpeton tribe. if any of you have a chance to work with either Sue or Melissa, they are just extremely amazing. Their foresight about they're trying to plan what they might expect as they do some of their interventions. And so we're working on, they were literally going to create case studies of, what to expect and what do you do if this happens and that happens. And so we're working with them now to develop some of those, and we'll try to maybe have them available to showcase them at the meeting in Minnesota later.
Hey, Pam, I'm going
to... yeah.
Yeah, so I'm sorry to break in. There's one thing I forgot to tell you, and it's hot off the press.
Yeah.
And Pam found this actually, but I want to make sure that we don't lose this. SAMHSA is giving out up to 45 grants, up to $800,000 per grant for first responder training under the Comprehensive Addiction and Recovery Act, and they're due May 6th. So for those of you who may be interested in beefing up work with first responders, you might want to take a look into that. All right, sorry.
And thank you. I'm so glad. And it's $800,000 a year for 4 years, so it ends up being like $3.2 million. And if I read it very quickly, it just came out a few hours ago from SAMHSA. So go to samhsa.gov, samhsa.gov, and then go to grants, and you'll see it. And basically, I think it said for rural communities, so it might only be for rural communities, but I know tribes were mentioned as a priority population. So that's some pretty decent money, and for 4 years. So hopefully we'll get some interest from some of you on the phone and spread the word. So we'll go through this pretty quickly, and we'd like you to start. If you have any questions, feel free to please start typing them in the chat box because we're in the home stretch here. Basically, the multi-component programs are ones that combine more than one type of strategy, and that address multiple risk factors. So it might address a lack of awareness, perceptions of harm, access, availability, overdose antidote use, and those kinds of things. So these are usually more successful. And I do want to say, too, about the overdose, that there's a lot of misconceptions that you can get high off of naloxone, otherwise known as Narcan. That's absolutely not the truth. I also want you to be aware of something that's very, very sick, sad, horrific, traumatizing that's happening, and that is for families that have there are some domestic violence perpetrators who are not only forcing women, also men, but mostly women, to become addicted to opioids, or they're going to methadone programs or other programs where they know there are individuals who are addicted to opioids, and they they kind of peel them out of line, or they attract them some way, and they pretend to be their boyfriend, or they help them in some ways. And then what they do, either if they're already addicted to opioids, or if they are in a situation where maybe they even just find someone that they induct into opioids and get them addicted, they then can use Narcan as a threat, because what it does is it throws the person into horrific withdrawal. I mean, it is just mind-numbing, painful withdrawal, because it brings you back to life by ridding your body all at once in this very dramatic fashion of all of this. And they're using that to force victims to do things, like if you don't have sex with these 3 guys, or you don't do whatever I tell you to do, and here it's a person addicted to opioids, I'm going to Narcan you. I'm going to, put this overdose reversal on you. And so a lot of these individuals, they know how awful that is, and they'll do anything to avoid that. So it's a form of sex trafficking. There's just all kinds of things that are happening out there that are very traumatizing. And so we just have to be aware, and we'll talk a lot about this at the conference or the TA meeting coming up in Minneapolis, that there's just a lot of different pathways that our clients are walking, and many of them have experienced, historical trauma and current trauma, and then you throw something this horrific in the mix, and, it's something we just need to be very aware of is happening. So multi-component programs combine multiple strategies. It might involve, coalition building, working with different sectors in the community, monitoring data on fatal and non-fatal overdoses, looking at prevention programming at multiple levels in the community, doing education around overdose prevention and reversal, evaluating program access, and identifying ways to improve. We cannot any longer tell people, oh, we can get you in, 2 weeks from Tuesday. I mean, we have got to get these folks in to care, and I loved Kathy's suggestion that these programs keep a space open so that if somebody ODs and you can, if you tell somebody, you have a peephole of opportunity when they overdose to where they're willing, they knew how close they came to death, they're willing to get help, but it's got to be available instantly, not 2 weeks from Tuesday. And that's really the case all the way around. This one project, Lazarus, which is highlighted here in a minute, they had some good outcomes in overdose death decreasing by doing this multi-component strategy. So did Communities That Care, CTC, and that also demonstrated improvements. We're going to show you the links to these programs. Iowa Strengthening Families Programs is another one that has had some success with kids and families using classroom curricula, but they involve kids and family interventions, and I think even some community connections. And so you can read here, you can see here in these sources, we give you a little bit more detail about these different programs. We're not going to go through them because you'll have to do them, take your time to go through them at your leisure. If any of these appeal to you. But there's a few more here, and then we'll wrap it up. Oh, the Project Alert and All-Stars, and then the Botman Life Skills Program, LST. I do want to show you, and then there's the Lazarus website at the bottom that had some really good outcomes. This is the Botman Life Skills. They are claiming that they have outcomes specific to reducing kids' use of opioids, prescription medications, and also their intentions to use in the future. And this is going in, I think, in the 7th grade classroom. But the key features of all of these programs, and the best ones for the most effective, what we call multi-component programs, involve ones that combine school, family, community, and outside social activities, address all forms of drugs. Remember that about 80 to 90% of opioid users use other drugs as well. If they're all nodding out and tired and worn out from opioid use, they might get jacked up on meth, or if they're all jacked up on meth and they need to function better, they come down with opioids. They drink, to take the edge off. So, there's a lot of combinations. And before I forget, when we were back talking about neonatal abstinence syndrome, they're now thinking a lot of the NAS symptoms, the more severe ones in the babies, are from moms who are using nicotine during pregnancy as well as opioids, and that a lot of that is actually nicotine. It's hard to tease out when multi-drug use is happening, so remember that's why it's always helpful to tackle multiple substances. The programs that are the most successful that are multi-component also strengthen family functioning, develop sustained relationships with caring adults, think about your community elders, tailoring to a specific population, build social and emotional competence, and increase connections between students and schools. So this is really taking you back to that whole socio-ecological model that we started with in the beginning of the big circle, reaching all those important levels. And to close, this is one of my favorite quotes. Prevention always constitutes a hard sell. It lacks the glamour of treatment. It can entail years of implementation, and when it's successful, it's usually invisible. In other words, how do you prove something didn't happen? We wish you well in your efforts. We'll take questions that you might have. I do want you to know there's a number of resources here. I'll page through them real quick before Jeff starts with some of his zipper, but you can see, toolkits, all kinds of toolkits, base toolkit. But I see we do have a question. The statistic for 1 of 10 that ODs is shocking. And they wondered if they heard that correctly. I'm trying to remember what that was. Kathy, do you remember which statistics that 1 in 10?
That was in one of yours. I'd have to go back and look.
Yeah, I will go back and look to make sure because I'm drawing a blank on that one. But the source of it is of all the statistics is on the bottom of the slide, and also in the notes pages when you download this, and it's also in the references. So, Jeff, I don't know if there's any other. Oh, thank you for information that Narcan is a weapon of abuse. Pass that along to the DV community. Excellent. Yeah, it's pretty horrific what they're doing with that, and it's a compelling way to control. And opioids are used to control. I've worked with more women than I can count that were forcibly injected by partners or were tricked into taking opioids. You know that it's possible. One of the ways you misuse opioids is you can take the powder out of a capsule. The capsule is supposed to be time released, but if you take it all at once, by opening the capsule and snorting it or opening the capsule and chewing it, there are ways to get a really huge bang. And so sometimes those are used to get people addicted, and they're not aware that that's what's happening. A lot of these opioid medications are being made tamper resistant. I know that OxyContin, they reformulated it, so now if you try to make it into a powder to snort or liquefy for injection, it becomes gummy. But the unintended consequence of that is people are then out getting the stuff off the street. So they could have had a clean prescription narcotic, and now they're getting fentanyl, And Kathy, I did want to mention, I think you know this, that not only does the window to revive somebody reduce when fentanyl is involved, but it may take multiple Narcan administrations. That we're hearing 2 and 3 being used to bring somebody back who is either on a high dose of opioids or it has fentanyl in the mix. So, sometimes these teams have to use a lot to bring somebody back. We will go ahead, Jeff, and you can do your thing, and I'm going to try to find the 1 in 10 slide.
Oh, okay, sure.
And Jeff, if you're talking, okay, I can't hear you. Okay.
Before I forget, I just want to give a big thank you to Kathy and to Pam for presenting today, and for everyone who used their time to attend. We do want to hear your questions, so please, if you have more, just enter them into the chat box. Otherwise, when you leave the meeting or when the meeting ends, you'll be redirected to a GPRA survey. It should take you less than 5 minutes. We'd really appreciate your feedback.
And we'll remind people about our pool meeting. Jeff, will you tell folks remind them about Minneapolis? About Mystic Lake?
Yes, of course. I want to remind everybody, all the tour grantees on the call, that don't forget to register for our TA meeting at Mystic Lake, Minneapolis. That is coming up in just about a month now. The deadline to register is next Wednesday, so March 13th. In fact, I'm going to provide a link to our registration site in the chat in case anyone still needs it. But please check it out. There's plenty of details, and if you have any questions, you can contact me at the email under Contact and Support. Oh, it looks like we have some more questions.
Great. It's right after. So the question is right after the naloxone slide. Jeff, can you pull that up while I'm looking at these other questions? We're looking for the naloxone slide, and I can try to figure out which one that is too. In rural Alaska, meds, including opioids, are prescribed by IHS-funded healthcare providers like YKHC. Is there any way to monitor opioids in a better way? I don't know, Kathy, do you have any thoughts about that? So we're talking in rural Alaska, and they're looking for ways to monitor opioids. The only way that I know is, I see. The only way that I know of is either by monitoring through the prescription database, where you know that there isn't a doctor giving somebody multiple prescriptions, or that you don't have somebody coming to the CVS pharmacy or wherever they go for their pharmacy and they come from a very long distance. That's a real clue. If they're coming a far way, you know, and from where their address is, that maybe they're hiding something. You know, education of others, of prescribers, education of patients. I don't know, Kathy, is there any other thing you can think of while I answer this last question on the 1 in 10?
Yeah, I think it's really, I think a lot of this is community specific. And so it's getting the key individuals together to figure out how to best do this. And I think talking to other rural communities about how they're doing it might help. Because I don't think, I mean, with all of this, not only is there no easy answer, but a lot is community to community specific. So I think it's getting the right people in the room who are committed to making a difference and seeing whether or not there's a way to kind of work that through.
Thank you. And the slide is up now. And so what this was saying is that, and this was a study done in Massachusetts that said that 10% of the people who experience a non-fatal overdose will be dead within 2 years following that first non-fatal overdose. So in other words, for every 10 people in your community that overdose and live, 10% of them, 1 in 10 of those people that overdose will likely be dead in 2 years. If those statistics hold in your community like they have in other places around the country, and like Massachusetts. That is the biggest risk factor for future overdose is past overdose. Because what happens, and this is just kind of hard to wrap your head around, but when somebody, and I've worked in methadone programs for years, I've worked with, you know, 39 years I've been doing this and been working with heroin users that whole time, that basically when somebody overdoses, instead of saying, oh no, like that could have been me or that could have happened, they say, wow, where'd they get their, you know, their stuff? I use a different word. But where'd they get their stuff? That must be some good stuff. And obviously I'm substituting the word stuff for the other S word, but that's what they say. And they because what happens is, and this could be a whole other webinar, but basically when you use the first time, the high is so incredible that they chase it the rest of their lives. They never will get another high quite like that, or rarely do they. So when they hear that somebody went down on it, you know, then they're like, well, maybe that's the good stuff. Maybe I can get that same good experience again. So it's not a deterrent like you would think it would be in many instances. In many instances, it propels people to want to go round up whatever that person did. So, yeah, so 10% of those who OD will be dead in 2 years, again, from another overdose, which is why we cannot do drive-bys. We cannot take them let them go to the ER and then just go home and learn their lesson. It doesn't work like that. We can't just schlep them over to a detox them, and say, you know, now you got all that drug out of your system, you're good to go. These drugs or these addictions are years in the making, and they take years to come out of, and it takes lots of strategies, patience, time, evidence-based practices. You've probably heard the saying, if it takes 3 years to walk into the woods, it takes 3 years to get back out. That's basically true. It takes years for them to develop, and we got to work with them too.
Pam, let me just say 2 other things. Yeah. I think you brought up an important point, and that is, so the individuals at greatest risk for overdose fatalities are those leaving detox facilities, those leaving residential facilities, and those leaving jails or prisons, because their tolerance has been brought way down, and if they're using at the levels they were using pre-incarceration, pre-residential treatment, pre-detox program. So that's an important point to consider. And then the other thing that I wanted to just say briefly, I was just looking at my notes of a couple of things that I wanted to say, is there's been discussion that all tribal communities are against medication-assisted treatment, or that there's a real stigma associated with that. And, you know, I certainly can't speak to that directly, as I am not a member of a tribal community. But what I can tell you from what we're seeing is that right now there are 19 states that have brought tribal community members into medication-assisted treatment. So there's roughly almost 900, it's like 831 individuals who are members of tribes throughout the country who are successfully taking MAT right now. So I think, again, we tend to overgeneralize sometimes, and so there may be certain communities where MAT is stigmatized and maybe poo-pooed upon, but there are also other communities who are recognizing its value and who are addressing the stigma that may be associated with it in the country, not just within tribal communities. So I just wanted to put that out there for you.
Thank you. And they're also, and if you are able to join us in Minneapolis, you'll get to hear some of these, that they're also embedding cultural practices and traditions in concert with the medication-assisted treatment in some real innovative ways. So, we encourage you to come learn from each other. You're the experts in your own communities, and you know what makes sense culturally and with whatever population you're working with, age-wise and otherwise. So, I hope you can join us in Minneapolis. If not, we'll try to address it in other ways. Anything else, Jeff?
No, nothing from me. I just want to say thanks again, and please make sure to fill out the survey following this webinar. Other than that, have a great rest of your day.
Thank all of you for the work that you're and thank all of you for the work you're doing. It's very important, and we appreciate your time today.
Thank you, guys.
See you soon. Bye.